All right, so we left off with meningitis last week. You guys remember meningitis from neuro, right? Inflammation of your meninges, covers your nervous system. It's real simple, really easy, nothing hard, right? 3 layers of meninges, right? The dural matter, your arachnoid matter, and the pia matter. Right? Inflammation of the meninges is from when you have symptoms. The folks that are usually the most at risk for this are usually the immunocompromised folks. Now, the other thing that's a little bit different with this one are folks that are unimmunized, right? Just like the immunocompromised, but with this one, folks that have abnormalities in their nasopharynx, right? When we talk about folks with cleft palates, people like that are also more at risk with this because it gives it a more direct path into the neurologic system. Okay. Here I tell you 3 different ways, right? Nothing different than we didn't already see before. It can invade the bloodstream. It can go retrograde into your neural system, right? That would be varicella or HSV that sits in your nerves dormant until your immune system drops. And then you have your direct continuous spread. That sinusitis and otitis media is the one that would really affect more folks with cleft palate. Okay. Significant cause of morbidity and mortality, 3 cases per 100,000. So this one's a lot worse than encephalitis itself. Before we got influenza B vaccine, influenza B used to be one of the real bad ones for mortality rates, but now that we do, it's gone down drastically. There it says decreased meningitis by 90%, so great numbers. There it says N meningitis most commonly in adults and children. Okay. When you think of N meningitis or Neisseria meningitis, think about young adults. All right. Think about people living in crowded groups together, like the barracks, like the dorms in colleges. All right. Okay, so here's some signs, symptoms: fever, headache, neck stiffness, photophobia. So nothing that we haven't already seen, right? This is stuff that we've already seen before. Nothing new. They've got the classic neck stiffness there, right? They've got a triad there in 2/3 of patients. So you've got fever, nickel rigidity, and mental status changes. Okay, so I'll probably highlight that. Anytime you have any kind of intracranial pressure, you may also get papilledema. That's pressure that's being put onto the optic nerve. Okay, we're causing that optic disc to swell inside the eye, causing you that papilledema. All right. Guys, remember Koenig sign? Okay, real quick, real easy. Lay the person on their back, flex that knee up, and then try to bring that leg up above its knee. The person's going to start resisting because it's going to cause some pain. Right? One of those tests to check. Guys, remember Brzezinski, same deal. You lay your person on your back, you're going to flex the head, the knees flex up because you're irritating that meninges. All right, so HIV patients, elderly patients, neutropenic patients, you have to have a higher index of suspicion with these patients because their immune system isn't up to par, correct? And if you know their immune system is not up to par, they will have atypical presentations. If they have atypical presentations, all the stuff that you're expecting to find, you may not find. You may try to do a Brzezinski's and they're fine. No problems. Right? But understand that immune system is dropped, so you're not going to get as much fight in the body. So you have to have a much higher incidence of suspicion for these folks. And that would also include neonates. Okay. HPI, biggest deal for IB. So depending on the time of year, history of exposure, right? Remember that the sooner you figure out what it is, the sooner you can attack the problem, right? So the longer you have it, the more permanent the neurologic damage that this thing causes. So the sooner you can get as much information from them so that you can figure out what's going on with them, the sooner you can target the problem. Because we're not necessarily dealing with meningitis as much as we're dealing with what's causing the meningitis. Okay, so here it tells you that the cornerstone is your CSF, right? You can do serology. That nucleic acid amplification test is NAT testing. NAT testing is basically a higher level of PCR. So that's technically a PCR. So you can do PCR for meningitis. Okay. It's probably one of your better bets, but CSF is key because it's going to kind of tell you what it can possibly be. All right. And just remember, no lumbar puncture to draw CSF. You have intracranial pressure. Right? That is a contraindication. So there it tells you CT or MRI. It can show you that there's something there or something's going on, but it's really not diagnostic. It can't tell you what the problem is. And we really need to know what the problem is so that we can target the problem. That's the big deal with meningitis and encephalitis. Okay. Make sure if you are going to do serology or PCR, make sure you draw your labs before you decide to start giving them meds. Okay. If you start giving them meds before that, you may mess up your lab results. Okay. You need to know this chart. Okay. 2 reasons. 1, I think I put it on the test this weekend. 2, you should probably keep it in your pocket when you're working in the emergency department. If you ever need to do an LP and you get CSF results back from the lab, the results are going to look like this. White blood cell count, glucose, protein. Okay? And that's going to denote what you got. Right? Because if you don't remember the numbers, you don't remember the numbers. Until you do it quite a few times, you'll start remembering what the ranges are supposed to be. Okay? The only ones that I remember doing this, I remember this one. Just because look how crazy this one is. This one is completely different than everyone else, and it's bacterial, right? That's the one that you need to figure out what to do. Opening pressures. When you put in a needle, they have a little gauge that you can put in there, and it'll pop up and it'll give you an opening pressure of your spine. In which case, that one's tricky. That one's tricky. It takes a little bit to play around with to actually get that opening pressure. So I don't usually mess with opening pressure. So I let the anesthesia guys deal with that stuff. But what you need to do is be able to collect the sample and send it off to the lab. If you're looking for bacterial stuff, this is the only one that has such gigantic numbers here. Anywhere between 100 and 5,000. All right. Greater than 80% PMNs. If you don't know what PMNs are, multinucleic cells, those are the ones that go to the front line. Those are part of your neutrophils that are on the front line fighting. So you're going to have a whole bunch of them out there because they're trying to fight this thing. All right. The other guys don't have it. The other guys actually have lymphocytes instead of neutrophils going to fight. All right. Your glucose is low. All the bacteria is eating the glucose for energy. So your glucose is going to be low. And your protein is going to be high because the vasculature is leaking out of your meninges. Okay? So although there's not supposed to be much protein inside there, you're going to get a whole bunch of protein, okay, in there because all the protein from your body is actually going in to your meningeal space, okay, which means you'll have greater than 100 protein when, if you look at the bottom down here for your normal levels, it should be between 15 to 40. Okay? So the only ones that I remember is my normal values and my meningeal values. Everything else I can look at. But the bacterial values extremely important because that's the stuff that really, really key. Now the other piece to this is depending upon when you capture your patient, when he actually shows up, and you do your initial lumbar puncture, and you send it off, it may come back normal, it may come back negative. Okay? In which case, if you are having some suspicions, especially based on history and physical that you just did, and you think that it still may be neurologic, and some neurologic signs start developing over a couple of hours, okay, I would suggest you do it again anywhere between 12 to 24 hours later. You do another one, and you send it off, if anything, for comparison, or to see if the lab messed up with the first sample, and now you may get some results with that. All right. Questions on the chart? Yes, sir.
So are we going to get the normal values, or so we need to know? Okay. Sorry. Great question.
Everybody hear what he said? No? He asked if you were going to get the normal values. But I can probably add them on there if you want. Let me write that down. All right. Okay. So these are just things to remember. And meningitis, number one cause of bacterial meningitis, children and adults. Again, remember, young adults, not necessarily as much children as adults, but young adults. And the reason why I tell you that is when someone is going to live in a dorm, if you're going away to college, this vaccine is required. You get this vaccine when you join the Army. You get this vaccine because you're going to end up living in the barracks with a whole bunch of other people. So remember, crowded spaces, living cramped together, this is a huge problem, right? And there's other two that can cause it, right? And then meningitis at the bottom, most common in neonates is that group B beta hemolytic strep. Remember that one, right? The mom can give it to the baby during natural birth if we don't give the mom IV antibiotics, right? A couple hours before birth. So those in mind. All right. So common cause of bacterial meningitis, streptococcal pneumoniae. All right. How do we treat these things? Either ceftazidime or ceftriaxone and vancomycin and dexamethasone. Okay. So you're going to give 3 different medications. You can pick either of the 2 cephalosporins, your choice. Okay. But you need to make sure you use vancomycin and dexamethasone. And dexamethasone is going to knock down the inflammatory process that's going to occur. Right? And here it's showing you pretty specific stuff for streptococcal whenever you do your CSF here. Okay. Now, we do have PCV. Okay. If you don't know what PCV is, that pneumococcal conjugate vaccine. This one is PCV13. Right? There's a whole bunch of different serobars of strep pneumo. So usually we'll give strep pneumo to babies when they're born. They'll get the PCV13, and then folks greater than 65, usually we'll give the PCV15 because it covers 15 serobars, and then we got another one, PCV20, that covers 20 serobars. Most common bacterial meningitis in the U.S. in most ages. Okay, Neisseria meningitis is extremely bad. And think of those young kids going to college. All right. When someone has Neisseria, these things like to attack the smaller blood vessels. Okay, these things cause leakage, these things cause necrosis, these things can attack any place in the body. This is a pretty bad one. Okay. High mortality despite appropriate therapy due to overwhelming endotoxin cascade. Right? So not only does this thing release toxins, but this thing also loosens the joints between endothelial cells, okay, causing DIC as well. So it causes a lot of serious problems, especially if you don't take care of it sooner rather than later. Now you've got asplenic people and terminal complement deficiency people. That terminal complement deficiency is a genetic issue where you have complement membrane attack complexes, which would be C5, 6, 7, and 8. And what those things do is that they help the cell understand that they have to lyse themselves. They help the cell understand that it needs to go and do cytotoxic killing. It helps the body understand that when cytokines are released, pro-inflammatory processes have to occur. So when you don't have those with terminal complex deficiency, your immune system is not working as well as it should. So this one's even worse. Okay. So I need you to know this slide. All right. There are 6 different serogroups for Neisseria: A, B, C, W, X, and Y. Different serogroups affect different parts of the world. Okay. If you look at that second statement, Group B is most common in the U.S. College. So that says college. So if you were, or if you went to college and you stayed in a dorm, you probably got Group B meningitis vaccine. That is generally the vaccine that we get when we join the military, especially if we're going to end up in the barracks during basic training. Keep that in mind, because that is very specific for the U.S. There's 3 specific ones in the U.S. B is the biggest one, but B, C, and Y are the ones that usually affect folks in the U.S., B being the biggest one and the worst one. Okay? If you look at the next statement in the Hodge, A and W are required. Okay? So when you apply to go to the Hodge, one of the things that you have to show is your meningococcal vaccine, because you're going to be in such a great close contact quarters when you're in there. Okay? And there you can see sub-Saharan Africa, typically A, but also X and C and W. And then the treatment is the same. And you pick one of the cephalosporins, cefotaximine or ceftriaxone, vancomycin, and dexamethasone. I wouldn't concern myself too much with that last thing where it says some give PenG. Anywhere you go, it's really dependent, right? So make sure you look at your SOP wherever you're at, because it's going to kind of guide you towards how you're supposed to treat meningitis wherever you're at. And that's due to the resistance that's being brought up to a lot of our antibiotics. Okay. Africa, 1 per 1,000 patients. Okay. Up to 1 in 100 young children. So big issue, big problem in Africa. All right. College students in dormitories. RR is relative risk. So college students in dormitories, and you can include our basic trainees in the barracks, are 3.6 times higher to get Neisseria meningitis if they don't have the vaccine. Okay. Keep that in mind. And there's the vaccines right there. We have 3. 2 of them are there. So meningitis ACWY, meningitis B, excuse me, and then meningitis ACWY, WY. Okay. Yeah, just remember listeria. So listeria in this case setting, it's cell-mediated immune deficiency there. If you guys remember that, it's when your immune system just starts going down for for a reason, and this reason in this case would be folks greater than the age of 50, pregnancy, alcoholics. Don't forget alcoholics. Alcoholics have a seriously depressed immune system due to the alcohol abuse, and in some cases also have mental status changes. And then steroids, which cause immunosuppression. Neutropenic folks should be on there as well. Transplants, HIV patients. Anybody who has a problem that's causing them to have a decreased immune system would be more at risk with listeria. Now, listeria is the only one that has different medication to take care of. Okay, in this case, it's ampicillin and gentamicin. Okay, the reason the difference is because cephalosporins do not work on listeria. Okay, all the other ones had cephalosporins as part of their medications. This one does not, because it does not work on this bacteria. Keep that in mind. Okay, so what do you need to do? Isolate 24 to 48 hours, whether it be viral or bacterial, doesn't really matter. Okay. Antibiotics for all patients with meningitis. Now remember, culture sensitivity is drugs to bugs. We have to figure out what is the cause of the problem in order to be able to develop a specific drug treatment for that problem. It's key to both, encephalitis and meningitis. Now, just like COVID, if you are a post-exposure person or a close contact person with someone who has been diagnosed with meningitis, you should get prophylaxis treatment. Okay? Here's your requirements. You are a close contact if you have prolonged contact greater than 8 hours. If you spent close proximity less than 3 feet. Direct exposure to patient's oral secretions, that includes boyfriend, girlfriend, significant other. Right? Hung out with them 1 week before the onset of symptoms. And then we, as medical personnel, doing certain things with patients, okay, in this case, contact with any of the airway secretions, CPR or intubations, we should probably also get treated. This one's also real simple. Ceftriaxone, or rifampin, or Cipro if it's not resistant. Generally, based on your location, right? So don't forget roommates, don't forget boyfriend, girlfriend that don't live with the individual person, right? Because they'll fall into that patient's oral secretions. So make sure that you let the preventive health folks know, because they have to go out and do contact tracing with these people, so that they can bring them in and get them treated prophylactically. Here's some, so all these can cause meningitis. There's just a whole bunch, and this is just a list of, or more so of differentials for viral, parasitic, fungal organisms that can cause meningitis. This is just a point to make. This is the United States here. Okay, this is the United States. This is a compounding formula that was made here in the U.S. Okay, tens of thousands of people exposed in 23 different states because they got this compounding medication from a pharmacy. 720 people got sick. 48 people ended up dying from fungal meningitis because they found Extralium and Aspergillus inside the compound of methylprednisone acetate. And they usually use that for epidural injections. So they were literally injecting people with fungus. Okay? This was purely accidental, but understand these things can happen, and it can still happen here in the United States. Okay? It's a rare case, but it can still happen here in the United States. This chart is for you. Maybe print, keep it in your pocket if you like, once you go to phase 2. Right? The only thing that this is doing for you is, depending upon how people present, clinical features, the one on the left, right? It'll give you a likely organism that you can possibly think that it could be, in which case you can empirically start treating for that organism until you get your culture and sensitivity back. All right? So So that's all this chart is there for. It's there for you to kind of keep great differential diagnosis, great way to kind of sort of lead you to a specific type of organism if you're not quite sure. Okay. So treatment, simple stuff. Stuff that we already know, right? If it's viral, you can probably treat it with some cyclovir. Right? If it's fungal, we'll probably treat it with some type of antifungal. Right? We have tericin, conazole, itraconazole, and those kind of medications. Right? If it's tuberculosis, right? Isoniazid, pyridomazine. Okay? What do we call it when? And then syphilitic meningitis. You have the two pens there. All right, your aqueous pen absorbs really fast. So if this is acute syphilitic meningitis, use the aqueous. If it's a longer going chronic, then you probably use the benzene. And aqueous is really absorbed really fast, but you have to give a lot of doses because it goes away pretty fast. And then benzene hangs out in your system, but it takes a long time to kick in compared to aqueous. Right. And then here's a bunch of differentials as well. You want to get smart? Somebody asks you what else could it be? Any questions on that? No? All right, next I want to talk about our prions. Not good stuff with prions. This is just an abnormal pathogenic agent that's transmissible and introduces bad proteins to your brain. Okay. Prions are proteins that hang out in the brain, and those are the ones that are specifically targeted with these things. Okay. It affects both animals and humans. Generally, humans can get it from those infected animals. All right. Now, there is a small portion of people that have this genetically, but when they do have this genetically, it doesn't predispose till like the 6th or 7th decade of life. So they do end up having long periods of life. The problem with this is that once the symptoms kick in, you have a very short time period. Once the symptoms kick in, you have a very short time period. And then you're done, because we have absolutely nothing for this. Nothing. Okay. This is a rapidly degenerating, progressive neuro disorder. Okay. This turns your brain into spongiform. Okay. And if you're not quite sure what spongiform is, just take a look at a sponge. It's got a whole bunch of little holes in it. That's what your brain looks like as this stuff continues to affect you. Okay? And depending upon what part of the brain is being affected is some of the type of symptoms that you'll have. Right? It's like every other neurologic issue. Okay? And the ultimate thing that this thing does, so prions are little spiral proteins in the brain. Okay? So just imagine a little spiral protein that looks like my hand. Right? What happens is this disease process just folds it in half. It just folds it in half on top of itself, completely negating what it does. And we have no lab tests. We have nothing to figure out that that's what it is until post-mortem. Post-mortem, we look at the brain, and then we realize that it's a prion disease. We get hints from how people show up, particularly with Alzheimer's, right? There's a really huge crossover, but there's really not much else that we can do with any of this stuff. And then those prion proteins, they affect cellular signaling, they do neuroprotective functions, they do cellular adhesion, they do interaction with other proteins. So when those things don't work in the brain, you're losing all of that stuff in the brain. Okay. So here's a little that's strangely unique. So this thing can be inherited. Right? You can have the trait or you can have the disorder. Okay. Trait, you have one allele. Disorder, you have both alleles, one from each parent. Right? This is non-sex, so both female and males can have this stuff. Creutzfeldt-Jakob disease is probably the one that can pass it on genetically to their kids. Right? And that one is more so of a mutation on their PRNP gene. And again, you can pass on trait or you can pass on disorder based on parents. This thing is initially slow. Here it's telling you it's got long incubation periods. All right. But once those symptoms kick in, there's rapid progression. Rapid progression. Okay. And it's always fatal. All prion diseases are fatal. They are always fatal. We have no vaccination. We have no lab tests to do to figure out that that's what this is. We have no medicines to give to slow this thing down or anything. So these guys are pretty tough. Okay. Here's some of the signs. All right, if you do end up with a genetic issue, it may present in your 6th or 7th decade. You'll have some dementia, multifocal neurologic dysfunction. Okay, so some of this stuff initially ends up looking like Alzheimer's until it starts developing more, where you start getting neurologic cognitive dysfunction. And you start seeing people just go down. They'll start having mental status changes to the point it goes beyond Alzheimer's. Right? They end up having twitching. They can't stop and control abnormal jerking and some myoclonic fasciculations that they won't be able to control. They'll have that ataxia where they have the inability to coordinate the muscle movements. They have somnolence where they're just sleepy, and they just don't want to wake up. And this all just continues to become progressive over time. There it's telling you they're trying to develop some PCR stuff. We don't have any. If you look to the right, there in that picture, those little spirals, those are your prion proteins. Those things usually we call alpha helixes, but then when you fold them in half and they no longer work, we call them beta helixes. Okay. And all this stuff just leads to prion diseases. Or transmissible spongiform encephalopathy is another name that we call some of this stuff. You can do lumbar punctures there. Doesn't really show you much. You can do MRIs. Not really going to show you too much. Okay. There is a specific protein that you may find in CSF called protein 14-3-3, but not always there necessarily as a biomarker. Okay, treatment? No specific treatment. Right. If you do eat an infected animal, the brain and the eyes are usually what holds this the most. Some folks like to eat these things, especially from cows. That is a way to spread it. Got cerebral electrodes. So they've been doing some what we call deep brain stimulation for some of these guys with experimentations, where they take electrodes and put them into their brain and they try to stimulate certain areas to kind of bring them back. Hasn't really shown too much effectiveness, but it is a means to try to stimulate the brain a little bit more than it gets once it starts losing all its prions. Those electrodes, those pads, will contain the infection. The infection has to be specifically cleansed, cleaned, and sterilized. If you put it into a standard autoclave where you sterilize regular instrumentation that we use for surgery, will not kill prion disease issues. Okay. So these things get cleaned in a special way compared to all the other instrumentation that we use for surgery. Now, chronic wasting disease is another name for what we call zombie deer disease. Zombie deer disease is prion disease in a deer. Okay? You can see the highlighted areas there where they found some of these zombie deer. And a lot of times those deer will just stand there. They really won't move much. They'll just stand there. And people can consume this meat and they can possibly spread it to themselves. All right? So one of those important things to keep in mind. Right? If you do find it in sheep is called scrappy. So another name for the same thing in a different animal. Here's a whole bunch of differentials. You want to be smart if somebody asks you. Might have any questions about that stuff? If somebody asks me later, I can check on the test to see if we have prion stuff. I don't remember if we do or we don't. But someone will have to ask me later. Might be something else you'll have to worry about. All right, questions? No questions? Okay. Maybe drive on. I will probably bore you with some of this musculoskeletal stuff. Right? You guys are elbow deep in orthopedics already, right?
Oops.
Yes? How many exams have you had?
One.
How many exams are you supposed to have?
4.
4? Right? Okay. 1D. Got it. Alright. So here we're just going to do superficial stuff. Nothing extremely deep. That's one of the reasons why you guys do ortho. But here we're going to talk about joint infections, bursitis, osteomyelitis, pressure ulcers. And the reason why we talk about infectious disease, number 1, this is a big issue. Number 2, MRSA, MSSA, strep, coagulase negative, strep. Right? All those things are very big causative agents for osteomyelitis or prosthetic replacement, where you guys really need to do culture sensitivity to figure out what's causing the problem so you can target this stuff. Okay? So nothing new. We're just going to kind of sort of gear it towards specific things. Right? Usually in patients with predisposing factors like endocarditis, diabetes, and trauma. All right? So we already know folks with comorbid conditions are always at risk. That will be this one. More so with diabetics specifically, right? Because you know that they lose cardiovascular perfusion in their distal extremities as the disease continues to progress, to include loss of sensation, right? Which predisposes them to infections. All right? Trauma, right? Because if you get hurt, you expose that bone, hey, guess what? Likelihood of infection is very, very high. Endogenous spread basically means once you get something and you get sick, it gets in your bloodstream is going to spread it around and it's going to get to other places in your body. Okay, and that includes your bones. And here it's telling you usually involves larger joints. In most cases, it's monoarticular, which means it'll attack one big joint, which is kind of one of those hints where it's like, okay, it's a joint infection because it's one big joint. Right? Simple. Okay. So here's some diagnosis. Okay. Sudden onset would be acute. Would be an acute infection, right? Acute infections for this is usually less than 2 weeks. Less than 2 weeks is what we consider a acute infection. Greater than 6 weeks is what we would consider chronic infection. We'll have a slide for that later, but just to keep you aware. With sudden onset, acute stuff, you have pain, you have decreased motion, you'll have fever, you'll have swelling of the joint, effusion, warmth, minor articular, usually right, one joint. Simple stuff, right? The warmth, the red, the fever, that right off the back tells you that there's some sort of infection, right? The swelling of the joint, the tenderness and the pain at the joint is going to tell you that that's the joint that's being infected. Simple stuff, right? Nothing big, nothing new so far. Knees, most common. Here you can see some lab results. Your ESR are going to be elevated. Synovial cell white blood count should be less than 200, all right? So what that means is the synovium inside your knee, in this case, the fluid that's in there, should have less than 200 white blood cells. When it's infected and it's swollen, in many cases, it will have more than 50,000. Okay? Or a number generally elevated depending upon when you capture it, greater than 200. Okay, so big key here would be, hey, draw some of that fluid off, and that's literally what you send off to the lab for culture sensitivity. All right. Here they've got culture is key to diagnosis. Drugs to bugs. Once you send that off, they will tell you exactly what drug you need to use to kill whatever's causing the problem. That is the key to a lot of this stuff. All right. In this case, it's going to be you drawing some of that fluid off, sending it off to the lab, and then telling you what to use. Generally, that fluid should be clear. When it's infected, it'll look a little turbid. It'll look yellowish. It may not be clear. Okay? So things to know. All right. You need to know this slide. Okay? Staph aureus number 1. Staph aureus number 1. Okay? For prosthetic joints, you have two things to really look at. Staph breaks out into MSSA versus MRSA. Okay? That will be dependent on where you are. Or coagulation negative streptococci, number 1 being streptococci epidermidis. Okay? Those three are the biggest problems for prosthetic joints. Okay? Staphylococcus epidermidis is part of the coagulated negative streptococci family, but that is the number 1 for that family to cause prosthetic problems. Okay? If it is a Staph aureus issue, then we just need to figure out, is it MSSA or is it MRSA, so that we can treat. Right? The nice thing is that MRSA and coag negative streptococci are both treated with the same stuff. Okay, so that's a plus. So you're only going to have 2 different medications there. All right. Neisseria gonorrhea, top cost for those under the age of 30. Right. If you don't have any serious trauma to a joint, right, and you're under 30, one of those high index of suspicion should be Neisseria gonorrhea for joint infection if you're under the age of 30, and we're looking at that because of stats. Okay. So with that said, how do you generally treat gonorrhea? Ceftriax, okay? If you remember how to treat gonorrhea, then you know how to treat this thing, Ceftriax. Nothing really has changed. Okay? And you got your mycobacteria and your fungal stuff, and then if it's viral, then it's viral. We can try to give some antivirals, but a lot of times you just let it try to figure out. We'll let the body try to take care of its own stuff with viral stuff. Okay. So if you're not aware, this up here is your normal joint, right? It's nice and smooth on the top and nice and smooth on the joint head, right? Nice equidistant spacing in between. But once the bacteria gets in there, right, it gets into your system and ends up through hematologic spread, or whether it be surgery, whether it be trauma or direct injury, right? Regardless of how it gets in there, it gets in there, right? So it provokes an immune response because it should not be there, so the body's going to try to fight it, right? Then it triggers more inflammation. As it triggers more inflammation, it starts pissing off this area up here, right? Both on the bone itself and on the head of the extremity. As that continues on, it starts causing more pain. Right? It starts causing that swelling that we see. It starts causing that warmth that we see. It also causes limited range of motion because it hurts to move. Okay? So that's generally the problem. And then as it continues on, it causes damage to the articular cartilage, which is one of the things that we really don't want, right? Because it starts messing up the joint. Okay. You can do x-ray, depending upon when that person actually comes in. If it has not progressed enough, when you do your first x-ray may be negative. But your x-ray will probably show some of the swelling, some of the edema. It may show a little bit, so if you really need to, you can, redo another one, or you can do a CT scan. You guys remember what a fat pad is?
Yeah.
From radiology? I got a yes here and I got a like, sure. Whatever. Okay. So a fat pad on x-ray really provides you diagnostic information. But that tells you that there's changes in an appearance of that area. If there's changes, something going on, right? And if there's something going on, it might be swelling, it might be displacement. Sometimes it could be a fracture, it could be some sort of underlying joint pathology. But if you start seeing that fat pad sign, then hey, we need to take a better look at this, or maybe we need to get the radiologist to kind of review this wet read before we say, yeah, there's nothing wrong with it. Okay. So fat pad's important if you actually see it on x-ray. Okay, treatment with antibiotic, antimicrobial treatment, or antimicrobial therapy based against whatever the organism is that's causing a problem. All right. And we got the most common ones there, right? We got Strep aureus, which is the most common, and quag negative streptococci, right? Most common. Okay. You would go ahead and treat empirically with some of those based on what you think until you get your stuff back. Okay. Nothing hard, nothing simple. Right? You take a sample, send it off, and look for sensitivity. You think it's Neisseria gonorrhea, go ahead and treat for that. Right? The longer you let Neisseria gonorrhea go on, the more joints it can affect. Remember that from gonorrhea when we talked about it. Here it talks about drainage and aspiration. While you're doing aspiration, so you can send it off to the lab for that culture sensitivity. Number two, when you do some of that drainage, it may decrease that swelling, so it'll decrease the pain for that patient as well. So it may be helping the patient as well. That synovectomy, you're not going to worry about. That's synovial tissue surrounding the joint. That's removed. You wouldn't do that. The surgeon would do that. Okay. All right. So here's your drugs and bugs. MSSA, ampicillin or oxacillin. Stuff hasn't changed. Still the same from the last couple of classes we talked about. MRSA and quag negative streptococci. Okay. Vancomycin. If you do have aerugiosa, you can use ceftazidime, and if you have gonorrhea, there's your ceftriaxone. Good?
Good.
Nothing big yet, right? Okay. Septic bursa. Okay. And this is basically an infection or inflammation of the bursa. You guys remember what the bursas are? Okay. Small sacs that cushion and lubricate the joints as you move them, right? You got a whole bunch in your elbow, you got a whole bunch in your knee, and your hips, right? Most common for septic bursa stuff is your elbow and your knee, all right? And that usually happens when they get over-irritated, overused, damaged by trauma.
That never happened in the military.
Say again?
So that never happened in the military.
Yeah. Well, at least not in the Air Force. It happens in the Army. Okay, so septic infection, bursitis is usually seen superficial, right? Burses aren't deep, burses are usually pretty superficial, right? So, nothing big. Usually we see, yes ma'am. Oh. I wanted a question. Okay. Alright, so continue on with septic bursitis. Okay. It generally becomes infected when microorganism, either from inside your body or outside your body, affects the bursa. Okay. And from outside your body, it could be a cut, a scrape, a bug bite. Any of those things can affect it. Right? folks that are most common for this are usually plumbers, carpenters, roofers, and clergy, and the folks that are going up and down, working off of their knees or their elbows all day. And here's some signs and symptoms, right? You'll have may have a fever, trying cellulitis, so around the area of that bursa, it may feel spongy or like a water balloon when you squeeze it. Okay? It'll be red, it'll be irritated, it'll be painful when you push on it. Okay? And they won't want to move that joint because it hurts. Okay, so decrease joint movement. If you do have fever or cellulitis, you may want to draw some of that aspiration off, send it off to the lab, and it's also going to be therapeutic because it's going to not hurt as bad for your patient as well. Okay. Most common, Staph aureus, nothing new. One thing to keep in mind there, as you see in that second statement, maybe first sign of septic arthritis in a patient with rheumatoid arthritis. So you may get this with a patient with rheumatoid arthritis, just as a hey, this guy may get. So a history physical may lead you towards someone saying, oh yeah, my mom has rheumatoid arthritis. And you're going to treat this the same way that you treat the last thing that we talked about. It's either going to be MSSA or MRSA. Okay. As most common, but then when you send that stuff off to the lab, you'll do culture and sensitivity, and then you'll do drugs and bugs. Right? Simple stuff. MSSA, ampicillin, oxacillin, MRSA, vancomycin. Right? All right, osteo. Okay. You have two. You have an acute and chronic phase. Here we'll talk to the acute phase. Acute bacteria penetrates the bone, causing abscess formations. When deprived bone of blood supply, it becomes necrotic. Okay? So you need to understand that once the bone gets infected, depending upon where it's at in the bone, that area of the bone, that blood supply may get cut off. If that blood supply gets cut off, that bone is going to become necrotic. Any antibiotics that you give that person may not get to that point. Any antibiotics you give to that person may not reach the point where it's infected in order to try to make it better. So necrosis in the bone is bad. Okay. So acute, less than 2 weeks. We kind of mentioned that earlier. Now the difference between acute and chronic here would be that acute is recent onset, sudden onset, okay, rapid onset. You'll have fever, you'll have pain, you'll have swelling, it'll look like cellulitis if it's closer to the outside, right? Technically we're talking bone, right? The nice thing about acute stuff is that it's reversible, okay? Generally within acute, it has not reached the necrotic stage yet. So the sooner you can get meds on board, the better off that outcome is. Right? And what do you think the most common is for this one? Staph aureus, right? Nothing different. Staph aureus. Okay. So now, when we're talking chronic issues, okay, this is going to take several months. It's going to take a while. Now we're really talking about necrotic bone. Right? So generally greater than 6 weeks is when we put this stuff into the chronic phase. And into the chronic phase, now we're talking a slower, persistent issue or a recurrent problem that a person's already had that starts causing them the osteomyelitis. Okay? It just spread from someplace else. Right? Because it's chronic, your body's trying to figure out what else it can do. One of the other things that it can do is it can drain or it can cause sinus drainage. So it'll create a little pathway from the bone through the tissue all the way out to your skin, and it'll start oozing out that way. Okay, you'll see that in chronic stuff, not necessarily acute stuff. But here's the deal. Wherever you see that if you have that sinus drainage, do not take a sample from the sinus drainage. Okay? You may be oozing stuff out, but you don't need to collect it. That is a dirty sample. It is mixed with a whole bunch of other flora, in which case you will not get the appropriate answer that you're looking for if you're using that as your sample that you send off to the lab. In this case, usually what you'll do is you'll go in and you'll do a bone biopsy. Okay. Because this is a chronic issue, you may have some low-grade fever, right, unlike acute. And this one may be a little bit more irreversible without surgery. Because you got to go in and you got to get rid of all that necrotic bone. Right? When that bone becomes necrotic, it's what we call sequestration formation. Okay? That is more of a technical term that we use for that necrotic bone within the osteo. Now, the other problem with osteomyelitis with chronic problems is that it may not just be one bacteria that's causing the problem. It may be polymicrobial, which means it may be multiple things that are actually affecting this bone, causing you the problems. Okay. And here it's telling you, hey, if you got acute, your likelihood of getting chronic is pretty high, especially if you don't treat. All right. Okay, causes. Here's a whole bunch of different causes. Trauma to periosteum. Okay, so you damage the bone. And there's open fractures, deep wound, surgical infection, bites, okay, contiguous spread. That one may be polymicrobial, okay, Staph aureus being the most common. But there you have abscesses, diabetic ulcers, post-op wound infections, okay, post-op wound infections for osteo. And then you have your hematogenous spread at the bottom there. These are some pretty bad numbers for folks that have osteo. I know this one's not going to be on your test, but it really puts you into perspective, right? So osteomyelitis occurs in 50% of ulcer patients. Okay? Ulcer patients are folks that have a lot of pressure on the skin that ulcerate down. You see those folks in comatose patients, or you see those in nursing home patients. Okay? Patients that are in the same position for long periods of time. But then of that, ulcers proceed approximately 85% to amputations. That's a pretty big number. Okay. The next one is approximately 60% of patients undergoing lower extremity amputations have diabetes. You have to stay on top of those guys because they have that neuropathy, which means they may not even realize that they have an infection or broken skin. That puts them at risk for an infection. So diabetic ulcers, for example. Right? In which case they may have both aerobe and anaerobe bacteria causing problems. And there it tells you, following the lower extremity amputation, 5-year mortality rate is expected at 60%. So 60% of folks may die within that 5-year time period. Okay. So the numbers don't look good for folks like this. So the sooner we can address it, the better off we're going to be. Okay. So you guys need to know this slide. This is on the test. Okay. This is the National Pressure Ulcer Advisory Panel. They're telling you and they're going to describe to you what each stage of pressure ulcers are. Okay. Stage 1, intact skin with non-blanchable redness. That means that your vessels have been damaged so much that when you look at the skin, it's red, and you push on it, the redness does not go away. Right? Simple stuff. Stage 2 is a partial thickness or loss of the dermis. Okay? Presenting as shallow open ulcer with slough. Okay? So what's slough? Slough is a bunch of dead tissue that forms over the wound bed. Okay? It's a collection of white blood cells. It's a collection of other debris that is just coming into contact with it that may be covering up that ulcer. Okay? It may also be intact or open blister. It may be shiny. It may be dry. If it's shiny, it means it's usually wet. but it may also be dry, okay? Could be a little shallow. So that one's not that bad, right? Then you get to stage 3, okay? That's full thickness loss. Okay, in stage 3, you can actually see your subcutaneous fat. So key for stage 3 is visualizing your subcutaneous fat. Okay, you may have some slough, right? That'd be that yellowish, tannish, whitish collection of white blood cells or dead skin cells that are accumulating there. That's what slough is, right? You may have some of that in there too. But then here you may also see some necrotic tissue. Okay. But the key point for stage 3 is the visualization of your sub-Q fat. Right? Because when you go to stage 4, you've got that full thickness with exposed bone, tendon, or muscle. So you've gone beyond the sub-Q fat layer, and now you've got exposed, or you can visually see bone, tendon, or muscle. You may see slough there, but then you also may see eschar. If you remember what eschar is, that black or brown, it forms when tissue has undergone necrosis. So that may be there as well. Now, if you have a whole bunch of slough and you have a whole bunch of eschar, it may block up your ability to see inside that wound, right? So if you can't see inside that wound, we don't consider this a stage, but we consider this unstageable. Now, with that being said, you have to explore or debride the wound. Okay, there's a little probe that we have that's got a really blunt tip on it, and you start poking in there. And you start pulling stuff out so that you can figure out how deep that ulcer goes until you can figure out how deep it goes so that you can stage it. All right? That's what the unstageable one is. All right, so here's a picture of blanchable versus non-blanchable. You look at the one on the left, when the guy pushed it, it still turned the little color back to the skin color. If you look to the one on the right, when you pushed it, it did not change color, so non-blanchable. But as you can see, it's still superficial, right? It's still superficial skin, and there's no break in the skin. All right, so good way to denote the difference. All right, that's stage 1. Okay, no break in the skin, but it's really, really red and it's not going to blanch. Step 1. Simple, right? Here's your step 2. Okay, it has broken through the top layer of skin. It's going down. Okay, that may be shiny, may be dry. Okay, depends on if you've made it to this point. If you catch it a little earlier, before it actually ruptures, it may just be a little blister. And once it ruptures, it'll start going down. And that's when you may see a little bit of slough. That'll be part of the dead skin cells and white blood cells that are accumulating and trying to make things better. Okay, so here's your third. Okay, full skin loss. Right. Now you're going further down. Okay, here's your sub-Q fat layer, right under your skin. Okay, we're down into the sub-Q fat layer. So if you were to look down into this ulcer, what you would be seeing would be sub-Q fat. Okay, sub-Q fat is technically yellow or white when you look at it. Okay, so it's very dependent, but a lot of times it'll be really easy to note the difference. Okay, so stage 3. And there's your stage 4. Okay. So in your stage 4 here, you have some necrotic tissue already forming on the sides. Right? But look, you're way beyond your sub-Q fat. You're down into your muscle and into your bone area. Okay, your ligaments and tendons. Right. So, real quick, easy way to know differences between all your stages. All right, this is the unstageable. So here's your eschar. Here's your slough. What you would do is you would just take something and start poking through here, see how far down you can go, and then start removing some of this stuff to figure out if it's actually down to the bone or to the muscle. Okay. Debridement is key for this because you have to remove all the bad stuff that's not helping the wound actually heal or get better. Other things that you need to keep in mind would be any kind of medical devices that apply any pressure to people's bodies. Okay, here it's telling you the nasal cannulas. The posterior aspect of your ears are very light with skin, and it goes straight onto the articular surface there for cartilage. Easy way for your skin to break, easy way for bacteria to get into your body. Okay? Foley catheters, IV tube pressure. So here's a whole bunch of different ways that you can end up getting other bacteria into your system that could spread to your bones. Okay. Here's your presentation. You may have plus or minus pain, muscle spasming, draining, sinus, plus or minus fevers, chills, plus or minus erythema. You can do some blood sample, right? ESR, CRP. Okay, those are definitely going to be up because this is an inflammatory type process. ESR, you can probably follow once you start treatment to see if it goes up or down. Okay. Before you give any medications, please draw all the labs that you're going to need, and then you can start your medications. With osteo, you can also draw blood cultures and send that off to the lab, but best bet would be a bone biopsy. Okay. And here it's telling you, do not culture from superficial sites like those draining sites that may form from chronic osteo. If you do give meds, please stop the meds for 48 hours before you decide to draw labs again. Okay, so if you look at the one on the left, you've got good density, right? Everything looks right, right? If you follow the outline of the bone, very smooth, okay? No issues, no problems. You can see some inner lining there, that's your bone marrow. Okay, it's where it's supposed to look. Because of the angle, you've got some lucency over here, but I think that's just the angle. And same deal, you look down, right? Fibula looks pretty good. Come over here, you're trying to do the same thing, but you've got all these black spots. Okay, this is all osteomyelitis. Right? All this is osteomyelitis. All right, you see this one starting to form over here. All right. Most common for osteomyelitis formation is usually the metaphysis, right? You have a distal metaphysis, you have a proximal metaphysis. Okay, we'll show you a little picture later. Other things that you may see on this x-ray when it's a little forward is you have things that look like this. See this like little sheath formation here? Okay, they were probably down here too, but since they're completely worn away, you just can't see them anymore. But that's what we call endosteal scabuli. Okay, and that's a radiologic finding. It's a concave scapula appearance along the inner surface of the bone, and all that means is that your bone is being eaten away. Okay. And that's kind of distinctive for osteo when you're doing x-rays. Here's another one here on a bit decreased joint space. I don't know if these are osteophytes. You can tell that this thing is completely swollen though. Okay. It's inflamed. Alright. Here's your osteo. Right here. Okay. Metaphysis is right down here in the bone. Okay, so what we call humeral osteo. It's on the humors. Alright, so let's play a game. What is this? What stage of ulceration is this? What?
4.
4. Okay. Alright, so just to be clear, I can see sub Q here. That would be 3. But I can see bone, I can see muscle. Right? Can't see bone, but I can see muscle. The bigger one takes it. The bigger one takes it. So this is definitely stage 4. Alright, because I can see muscle. This is a diabetic. Okay? This is a diabetic patient. Okay. A lot of times, if you choose to work in a diabetic clinic, a lot of times what you're going to do is foot exams, and you're going to see a lot of this. A lot of this. Okay. So affects the metastasis of the bones most frequently. All right, most frequently. The ones that you need to be careful with are the little kids, right? Because they have growth plates, and the metaphyses are just above and just below the growth plates on those little kids. So, gotta kind of be careful with that because it can affect their bone growth. Okay, so simple things. Staph aureus, most common. Coagulating, still a problem, right? Just like getting infections. You can also get all these other infections, cocci, gram-negatives, anaerobes, and diabetic feet. If it's a longer process for the diabetics, it can be both anaerobic and aerobic. So don't think that it's just one. It may be mono or it may be polymicrobial problem, depending on how bad the diabetic foot is when you're looking at it. And you have MRSA and joint infections, joint-associated infections that we talked about earlier. Okay, so I need you to know this part. Salmonella causes most osteomyelitis cases in patients with sickle cell. Do you guys remember why? You guys remember that in GI, folks with sickle cell had most salmonella problems because salmonella, for some strange reason, likes hanging out in the GI tract of sickle cell patients, right? So what happens with sickle cell patients? Those red blood cells sickle, hence the name, sickle cell, right? But what happens is, when they sickle, they start destroying tissue, which allows salmonella to get out. The other problem with sickle cell disease is that it destroys the vasculature inside the bones. And remember, there's not tons of vasculature in the bone, so once you start destroying some of it, right, because of the sickling, it's messing up those vessels, it creates decreased blood flow in some of the bone aspect, which allows the salmonella to grow unchecked, right? Because the body can't get to it because it's got normal blood flow now, right? So salmonella causes most osteomyelitis in patients with sickle cell disease. And don't forget the medical devices that also cause those kind of things. Right? Other pathogens include, okay, you want to be smart, there's a whole bunch of other ones. Some of these we've talked about, TB, Coccidio, Blasto, Histo. We haven't spoken about brucellosis. That usually affects livestock, okay? And it's transmitted to humans through unpasteurized dairy products. It's generally how we get it. Okay? Infection of the GI system causes us diarrhea. We can also get infected by direct contact with some of those infected livestock. It's not going to be on your test, but hey, there you go. All right, x-rays. Diagnostic x-ray may not be positive for lipid lesions within 2 to 6 weeks. Okay, so depending upon the time frame that you're going to be doing these x-rays for these patients is whether or not you're going to actually see some stuff. So if you think it's going to be osteo, keep it in mind when you do the actual x-ray. All right, it may take a little longer. The nice thing is, you can do an MRI or a CT or a bone scan, and you can get better answers within 2 days with this stuff. Okay? Just because it's a little bit more sensitive. All right? If you do see some endothelial scaffolding, you already know that you're heading towards an osteo. Okay? That's a big thing that usually you'll see on those X-rays. Okay? And here it tells you ESR, nice way to follow whether your treatment for osteo is getting better or getting worse. All right? And that's more so than inflammatory type process. Right? And the other thing you really need to do is just that bone biopsy. Once you get that bone biopsy done, send it off to the lab. Okay? And don't do culture samples from any of the sinus cavities that are formed from the osteo. And this is just a quick picture to show you, right? Here's your healthy growth, right? These little lines right here are your epithelial plates. Okay? If you look at where the metaphysis is right under those growth plates. Okay? So the most common areas are metaphysis, but look, it can interfere with your growth plate. For adults, not a big deal. Okay? We ain't getting bigger. I know I'm not going to end up being 6 foot tall. So it is what it is. So we don't have to worry about growth plates for us, but for kids, it's a little bit more concerning. Okay, so here's another picture with some osteoblasts straight out of that metathesis, which sits right here. Okay. Standard treatment, real simple, right? Standard is most common staph aureus, right? So MSSA versus MRSA, oxy or nafcillin and oxycillin versus vancomycin, right? If it's fungal, then we're going to treat with some sort of antifungal, right? For the fungal ones, generally speaking, for immunocompetent people, healthy folks, not usually a problem. Okay, so for us, fungal stuff usually is not a problem. Can we? Yes, we can. Usually it's not. Usually it's the immunocompromised folks, the neutropenic folks, the folks that have a lower, okay, immune sense are usually the folks that get contaminated with a fungal issue. And then TB stuff, you guys remember what we call TB when it affected the bones and spine? Pott's disease. There you go. Right? So if you have Pott's disease or TB in the bone there, you're going to treat with some sort of anti-tuberculosis drug combination of INH or rifampin or something to that effect. Okay? Your next statement's pretty clear. It's drugs to bugs for any of this stuff. Okay? It's drugs to bugs. You can treat empirically, which is what we're going to do with the nafcillin and oxacillin if you think it's MSSA. If you think it's MRSA, then we're going to go ahead and go with Vanco. Okay? But we'll treat it empirically until we get that culture sensitivity back. Drugs to bugs. And then other things that we've got down here, right? Acute perfusion of oxygenation, right? Do you guys remember HBOT? Right? Hyperbaric oxygen therapy. We do that. We have the viable tissue versus non-viable tissue. The non-viable tissue we should remove, right? To allow the healthy tissue to bring as much blood circulation to those areas as we can. And there, necrotic tissue acts as a physical barrier, devitalizing tissue. So if we can remove the bad stuff, we'll allow the good stuff to do its thing. Okay? And here it's telling you incision on the necrotic bone is essential for chronic myelitis to get back. Okay? Usually not us. We may go into surgery and assist the surgeon in doing that, but he'll go in and he'll start taking stuff out. Okay? Poor outcomes are common with chronic underlying illness such as diabetes, mellitus, sickle cell disease. Right? So anything that causes vascular damage to your body has a really poor outcome. Because remember, if you're trying to give me, if you're trying to make me better, you're trying to give me some IV antibiotics, and I want circulation in my body to get it to where it needs to go, can I get it there if the circulation's not there? Can I get it there if you have necrotic bone? Right? It's none. The answer is no. So I have to make that happen. So you have to remove that stuff. Okay? And the other piece there, when we talk to the ortho guys, once osteo, always osteo. That's a big thing for them. Because when they go in there and they remove stuff, they're not quite sure if they removed all the bad stuff. Right? And they're not quite sure if they completely treated it, if there's anything sitting in there still remaining that may end up bringing those people back. Now, why do we say that? So do you guys remember the word sequestration that I used earlier? That talked about the dead necrotic bone, right? So your body is a wonderful piece of machinery that I don't think we'd ever be able to duplicate, right? So your body tries to protect you from that. So your body does what we call an invulcrum. A bunch of different names for a whole bunch of different things in different parts of the body. Okay. So you have your sequestrum, which is the necrotic tissue. Right? Here's my necrotic tissue. The invulcrum will be your body's immune response to this necrotic tissue. What your invulcrum does is surrounds it and it encapsulates it and it keeps it from spreading. Yeah, stuff's not organic test, but body's an incredible piece of equipment, man. Right? So your body encapsulated, so the surgeon's gonna go in there, especially if he sees it, and he's gonna try to pull it all out. If he can, he will. If he can't, we don't know if anything is left back in there, which means once you're osteo, you're always osteo. Hence their motto. Okay, treatment should be pathogen specific, so your culture sensitivity, really specific. That'll tell you what it is. Consider bone penetration, right? If we have lack of circulation, or if we have a bunch of necrotic tissue or necrotic bone, it's not going to penetrate. Okay? If we have gram-positive, gram-negative stuff that you can treat, we say duration 4 to 6 weeks. PO after they give you the IV stuff. And AB is antibiotic impregnated beads. So when they do surgery, if they do take out a whole bunch of bone in there and they do have a gaping hole, sometimes they put fake bone in there. They usually don't, especially if it's osteo. What they will do is they may put antibiotic beads in there, so you have antibiotics going directly into your bone. Okay. Again, we won't do that, but the surgeons will probably do that. Okay, just to give it a direct blast of antibiotics where the infection is actually occurring. Okay. And then you've got the HBO for refractory osteo. That should be HBOT, hyperbaric oxygen therapy. Okay. If you remember that increases the blood supply to the affected areas. Right? Some of those are anaerobes, blasted with super oxygen, kills those anaerobes. Those super oxygen also increases the fight of those white blood cells. So it helps in a whole bunch of different ways. Okay. There's your impaired therapy, MRSA. Back up. Your second statement there with a nail through your foot, which you do have a lot of folks come into acute care for. We used to just go ahead and give Cipro. That would really be the thing to do. But now we're talking, we're getting a little bit of resistance to that Cipro. Okay, that nail through the foot can lead to osteo. So talk to whatever physician is, wherever you're going to be, and find out if that is enough coverage for a nail through the foot. But standard is usually Cipro. Okay. For those diabetics, it may be polymicrobial, which means more than one microbe is causing that problem of the ulceration of the foot. In which case you want to try to find something that covers both aerobic and anaerobic type of bacteria. Right? And you can see how long the therapy is for. But some of those meds would be augmentin, right? Cefoxetine. Okay? So those will be some meds that we can use for polymicrobial coverage. Clindamycin is one that we've used before. That's another one that you could possibly use. All right, prosthetic joints. Okay. Now, here's a whole bunch of stuff. Usually do contamination at time of surgery. Here's the problem with prosthetic joints. It's a logistical nightmare getting it from the place that it's made. In some cases, they may be pre-sterilized for you when it comes to you, but in that interim, you don't know what's happened to that joint, that artificial joint that they're about to implant into someone. Okay. So logistically, there's a whole bunch of places where that thing can get infected. Right? Okay, the general risk runs from 1% to 9%. Okay. Increased risk with diabetic patients. Diabetic patients always have an increased risk of all this stuff. Just understand that there's a lot of different places where this prosthetic joint can get infected before it gets to the OR to get implanted into you. Okay. Here's usual diagnosis is usually with onset of symptoms within 6 months of the operation. Okay, signs and symptoms similar to those seen in septic arthritis, you have fever, edema, swelling, tenderness, decreased motion. That's one of the biggest things that you have to be careful with when you're doing prosthetics, is make sure that they don't lose their range of motion. They're going to have decreased motion because it hurts and it's swollen, and sometimes they won't even be able to bend it. So rapid attention to this would be key. Okay, your ESR is going to be greater than 30. It's an inflammatory process. It's going to be high. And your CRP is also going to be high. Okay. Just remember, in osteo, you know, it says lab similar. In osteo, our key was to do that bone biopsy, right? There is no bone biopsy here. And here it's mostly going to be you drawing off fluid, sending it off to the lab. And then we could do some serology stuff, but just remember, there is no bone biopsy to do with a prosthetic joint. Okay. Here, if you do look at some rad findings, periostitis and endosteoscapular, diffuse osteomyelitis. Okay. Basically, you're seeing destruction of bone here. All your stuff. Okay. Treatment twofold: eradication of the infectious agent, and two, maintenance of the function of the joint. Okay. You do not want to lose range of motion of the joint. The sooner you can get that patient back into range of motion of that joint, the better off they'll be. Same deal with everything else. Culture and sensitivity. You need to eradicate the cause of the problem. Okay. Microbial treatment, culture sensitivity, what you're going to do. The surgeon has quite a few different choices. He can re-implant, he can do an arthrodesis, he can do an amputation, or he can try to implant, try to salvage that implant. Okay. A lot of times they'll try to salvage the implant, which means they'll open it back up. They'll flush, right? That solution to pollution is dilution, so they'll try to flush the heck out of it. They try to flush it with some antibiotics. If they want, they could drop some antibiotic beads in there as well. And then try to do delayed closing, and then close them after that, and then put them on a bunch of broad spectrum antibiotics until they get some specifics from their culture and sensitivity. That's usually what they'll do, because they'll try to salvage it the best way they can. Okay, so I added this in there just because I think it's kind of fun when I was doing surgery, because it's like woodworking. Okay, so let's say your tibia is broken, they'll take a plate and draw 6 holes in it, and then they'll screw 6 screws in there, and it'll keep your bone approximated and allow it to grow on its own. All right, these were one of my favorite surgeries with tibial intermedullary nailing. Right, so we had what we call reamers, were about a yay long. Okay. The tip was like a drill bit, but you could bend it in half. And then you basically take the drill bit and you just drill straight down the middle of the bone, removing all that bone marrow. And then you take a metal nail and you just hammer it into the bone. The nail will go in and it will go all the way down to about down here, depending upon where the fracture is. And then they'll put 2 screws here to lock it in place, and 2 screws up here to lock it in place. Fun stuff, especially for like woodwork. All right. Anybody have any questions? Okay. The slide, this one right here is key for you to understand when you talk to your patients. You need to be very clear on what you're saying, and they understand what you're saying. Right? I was so relieved the doctor said it was fractured. If you look at that X-ray at it. It's completely broken. Right? But the patient didn't think it was broken because he probably didn't understand the fracture. Okay? So be clear with your patients. Sometimes they don't understand some of the terminology that we have. Okay? Questions? No? You guys want to start on the next one? Or you guys want to call it quits?
Call it.
Call it quits, okay. All right. All right, I'll see you guys tomorrow.